Well, hi everybody, I'm Brin. It's now just over 10 years, or 3,661 days to be precise, since I had a major ischemic stroke. And today I'm here to talk to you about my recovery from stroke and how I think that I've achieved it through my involvement with stroke research. In the time-honoured tradition of medical research, I've given today's presentation a snappy acronym. So I've called it RECOVER, which stands for Rehabilitation Research equals Collaborative Ventures with Patients Enabling Better Results. And that embraces everything which I now believe in. Because I think that my recovery really started in 2006 when I volunteered to participate in my first stroke research trial. My brief for today from Sissy, I think I had a brief from Sissy, was to give a presentation on my patient experience of participating and contributing to stroke research. So the presentation will actually come to light in the next 20 minutes. But why the jumbo jet? Well, those of you who have heard me speak before know this is my reminder of the devastation that stroke causes in the UK every year. 152,000 people have strokes in the UK every year, which is the equivalent of one of those things going down every day of the year. Now that's pretty scary, isn't it? And when Sissy asked me earlier this year if I'd like to give a presentation for you all today, my first thought, I have to admit, was just get real, woman. It's got to be yes, please, because those jumbo jets full of stroke patients are still going down, day after day, month after month, year upon year. 3,660 jumbos involving 1.5 million people since I had my stroke in 2005. And then, hope this works, yeah, then I started to scream. Because when I thought about the list of today's delegates, I realised that many of you have heard me speak before. And since I last gave a presentation like this, which was in March of this year, I've moved on in my recovery yet again. So I knew that I'd got to do something a little bit different. So here we go. Let's see how I do. I'm going to start at the beginning because as that song once said, it's a very good place to start. Imagine a beautiful, clear, still day in late August. It's 7:10 in the morning. The sky's blue, the sun's shining, and you're on top of your game. Physically, emotionally, financially, and then it all ends in an instant. That was my personal tragedy on the 31st of August 2005. A brief moment of inattention by a car driver changed the course of my life, my wife's life, and the destinies of my 3 sons. One small mistake set in motion a real-life butterfly effect, with ripples that are still radiating out to destinations that I'd never believed possible. Because on that carefree morning, as I cycled to work, a 47-year-old husband and father of 3 teenage sons on a 20-mile commute to work, I was invincible. I was fresh from a 3-week family camping holiday in France, and I was fit, strong, and beautifully tanned. The next few weeks and months of a new term at the college that I worked at would be hell, but little did I know what personal hell awaited me, because by 4:30 that day, I was in hospital, totally paralysed down my left side, after suffering a massive ischemic stroke following a fairly minor road accident. That was some solicitors for the defence for the court case who described it as a minor accident. I'd had 28 stitches in a shoulder wound. That's a minor accident. But that was 10 years ago, and that's the reason that I'm here. A patient who medically had a severe ischemic stroke, who pragmatically has an acquired brain injury. I've had a stroke, but I have an acquired brain injury. Please note the tense change. But one of the most inspirational people who's had a huge influence on my recovery is the musician Edwyn Collins. Because when he was in the early phases of his recovery from a hemorrhagic stroke in 2005, which had left him with a significant aphasia, he uttered these prophetic words over and over again, according to his partner, Grace Maxwell. And the words were, the possibilities are endless. And I can honestly say the possibilities truly are endless. Because 4 years on from my stroke, by September 2009, I joined the West Midlands Stroke Research Network, following the return of a glimmer of self-confidence. But inside my head, in reality, I was still a very confused and frightened child. In fact, I was still quite poorly. I was racked with guilt from being forced to take early retirement in 2008 and besieged by psychological problems and cognitive deficits that I didn't understand and nobody had diagnosed. But it was at this point, 4 years after my stroke, that my real recovery started. I may have had a very messed up brain, but thankfully my memory was functioning well, and I still recall my first Stroke Research Network seminar given by Carol Williams at Birmingham University, delivering the results of the CLOTS-1 trial. Now, back in 2005, it was custom and practice for stroke patients in UK hospitals to wear support stockings to prevent DVTs and pulmonary embolisms, but there was no evidence that they worked. CLOTS-1 set out to see if they did make a difference, and guess what? They didn't. CLOTS-1 proved that they actually did more harm than good, because 25% of patients developed leg sores as a consequence of wearing them, and only 1 in 200 actually got some benefit. Now, that one research seminar had a massive impact on me in terms of my own involvement in stroke research, because I realised that the medical profession, whom I'd grown up believing was in fact was so evidence-driven, was in fact very far removed from the culture that I'd grown up with for the previous 20 years. And that came as a huge shock to me. And then 1 year later, in 2010, I was in the audience at the West Midlands Stroke Research Network conference at Aston Business School, listening to a young stroke patient give his personal recollections of his fight to recover. I sat in awe with tears streaming down my face, wishing that I too could retrieve the capability to stand up and give a presentation so eloquently. Well, I had to wait a few years before, just like the proverbial buses, several opportunities arrived in close succession. The first was in January 2011 at the Birmingham and Black Country Clerk Conference in Digbeth, followed in May by a speech in Westminster City Hall alongside Andrew Lansley. Do you remember him? That was for the launch of the new NHS Leadership Fellowship Initiative, and that's when I appeared on YouTube for the first time. But at the Aston conference, Carol Williams was presenting the post-revised NICE guidelines on the use of TEDs in acute stroke care, and it's both timely and very appropriate for myself that Professor Helen Rogers in Newcastle contacted the National Institute for Health Research Stroke Research Network lay members in March of this year for our comments in regard to the new proposed NICE recommendations on the use of intermittent pneumatic compression stockings in stroke care, following the publication of Martin Dennis's CLOTS-3 trial last year, which proved that their use has the potential to prevent 1,750 deaths per year from DVTs in stroke patients, or 17,500, about 40 jumbos, if they'd been in use when I had my stroke in 2005. So why am I talking about acute care when this presentation is about rehabilitation? Well, quite simply, if you don't survive your stroke, you can't be rehabilitated. It's really simple. And so that's my message to NICE when they next query whether mortality rates is worth reducing in stroke, because so many stroke survivors are left with life-changing disability. It takes a lot to make me angry, but the release of those proposed new NICE guidelines in March of this year made me apoplectic with rage, alongside every other lay member, academic and clinician that I know. But CLOTS-1 was my first real evidence of research having the potential to change clinical practice and improve the care and dignity of patients. And if you've ever had the indignity of having to wear TEDs, you'll immediately understand why attending Carol's seminars had such an impact on me. It was a really important moment in my recovery. And then more recently, the publication of the UBOS trial, coordinated in this very hospital trust, as I've been told, had an even more immediate effect in City and Sandwell hospitals, where care protocols have already been modified in the light of the publication of the UBOS results. For those of you who have not heard about the UBOS trial, you'll find out about it later today. But the outcome of UBOS was really satisfying for myself, because I was a member of the team that taught A-level biology many, many years ago at the Sixth Form College, Solihull, to Cameron Lindsay, the physiotherapist and researcher conducting the trial. Excuse me, I've just got a bit of clonus going on. And I was also a member of the UBOS trial steering group, working alongside Sissy, Steve Sturman, and Professor Andan Pandian and Christine Roth. And here I am, a passionate advocate for stroke rehabilitation based upon sound evidence-based practice, with a personal mission to ensure that trial protocols are always designed to be as patient-friendly as possible. And as an underpinning theme of my presentation today is transforming rehabilitation research in the UK, it's brilliant to walk amongst like-minded people, especially if, like myself, you've had to learn to walk again. So no more screaming unless it's at NICE guidelines. But by 2010, I was starting to feel more like my old self again, always asking questions, testing my understanding of my stroke with every small step of my recovery. And then I heard about the University College of London PLORAS trial, headed up by Professor Kathy Price. PLORAS stands for Predicting Language Outcomes and Rehabilitation Potential After Stroke. Why did I want to participate in that trial? Well, I'd had an MRI scan in 2007 at the Birmingham University Imaging Centre, so I knew where the damage in my brain was. The optimist inside me wanted another scan just to see if the brain had started to physically repair itself by the process of neurogenesis. That's the process where neurons in the brain regrow. It's a process that was thought to be impossible only a few years ago. But as Edwin Collins said, the possibilities are endless. Anyway, it was a long shot, but I love the idea that with stroke and acquired brain injury, you sometimes have to distance yourself from probability and embrace possibility. However, the PLORAS MRI showed no difference in the size or the distribution of my brain lesions. So why was I recovering so well? It just has to be the magical process of neuroplasticity, a concept that only gained some credibility back in the 1980s following the work of the brilliant young neuroscientist Paul Bacchi-Rita in the United States in the late 1960s. Today, the concept of neuroplasticity has finally reached the mainstream, and I'm living proof that it's real. It's said that a perfect marriage is just two imperfect people who refuse to give up on each other. That sums up my commitment to repairing my brain. But in 2012, 7 years after my stroke, I finally felt that much of the old me, but better informed, just as bloody-minded, and hopefully as eloquent, emerged from the broken man that the stroke had created in 2005. And when the call came from Dr. David Waring to be a speaker at the Stroke Research Network conference in Newcastle in September 2013, this is Newcastle, by the way, looks really nice at night, doesn't it, with the lights on? There was a significant uplift in my self-belief and self-confidence. But for the 2013 Newcastle conference, I used a very carefully crafted title for a presentation that I hoped would keep delegates back in the venue for my graveyard slot on a Friday afternoon at the end of the conference. It's lovely to have so many people here today, I must admit. For today's event, I thought about being really controversial and doing 20 minutes on busting stroke myths. But I'll save that for another day because that's not what today is about, though it remains one of the missions in my new life. I've learnt so much about good rehabilitation research and stroke from all of you over the past 10 years, and I've learnt a little bit more at every research meeting that I've ever attended. It's given me back hope, knowledge, ambition, and bucket loads of self-confidence. But here's some of the trials that I've been involved with since 2006. They're in no particular order of importance. I've divided them into the dark side of hyperacute rehabilitation and patient and care and public involvement. But one of the most precious outcomes of my involvement in stroke research has been the restoration of my self-respect and personal dignity. I've now been involved with well over 40 research trials in some capacity since my first rehabilitation trial with Trudy Pelton at Birmingham University School of Psychology as a participant in 2006. At present, I'm a co-applicant or collaborator in 5 research trials based in Kiel with a new unfunded as yet trial called DISCUSS. DISCUSS stands for Dynamic Induced Stretch for Contractures of the Upper Limb in Stroke. That's being led by Jane Bissicott and Professor Anand Pandian. And then in Stoke, a study that has been funded is Christine Roth's MAPS2 study. And then in Salford, somebody I've collaborated with for a long time is Kristen Hollands, who's leading the visual cue training trial. Some of you may have actually run the pilot for Kristen a few years ago. And then in Liverpool, there's the Investigating Vision in Stroke trial with Fiona Rowe. And at UCLAN, the HEAD-POS trial, which stands for Head Positioning in Stroke, which I know UHB are going to run. And that's being run by Professor Caroline Watkins at UCLAN. But the majority of my activities since 2006 have been rehabilitation trials, with 20 based here in Birmingham. For obvious reasons, they're close to my home and I wanted to get better. It's only recently that I've moved over to the dark side of hyperacute and acute research. But after 10 years of my own rehabilitation, I'm more convinced than ever that the future of stroke rehabilitation has got to be strongly directed towards the self-management of patient recovery in the most supportive way possible. This isn't a new idea. In fact, it's been around since 400 BC, because Hippocrates talked about the physician's duty to enable the patient. And I recognise this is going to require huge cultural and logistical changes to current NHS stroke rehabilitation services, but I think it could be done very cost effectively and to the benefit of patients and rehabilitation professionals alike. You'd have thought that I'd seen Toby's speech beforehand, wouldn't you? I haven't. So what's 2015 delivered to me other than involvement in several new research trials? Well, most stroke patients that I know are pretty generous and caring people. I've got to say that because I know quite a lot of you here. And they want to give something back in return for the care and support which they've encountered during their recovery. And I hope that I'm no different. And my reward for getting involved in research has seen an invitation to be a member of the Stroke Association's Strategic Research Group, working alongside Professor Tom Robinson, Professor Anne Forster, and Professor Pippa Tyrrell, some of the most influential clinical academics working in stroke research in the UK. I'm thrilled skinny at the prospect of being able to contribute to improving stroke outcomes at a national level. But hot off the press, on the 27th of August this year, I was invited by Professor Kamal Raza to be a patient representative on this very Trust's R&D board. The possibilities are most definitely endless for that butterfly effect that started in 2005. But I'm often asked by clinical staff, academics and lay people the same question. What's the most important piece of research that I've been involved in? I used to have no problem in answering this question, but since joining the old NIHR SRN Rehabilitation CSG, wow, that's a bit of a mouthful and a definite no-no if you're aphasic or have a significant dysarthria, which incidentally I did experience right up to 2010. But answering that question has become far more difficult for me. Only a couple of years ago, I'd have instantly replied to that question with BCOS, the Birmingham University Cognitive Screen, because it was the trial which resonated most with my personal experience of stroke. But then after hearing Kate Radford's report on her vocational research rehabilitation at a meeting in Nottingham last year, I'm now in a bit of a quandary. Because in reality, all the research that I've been involved with is important. As if it wasn't, I wouldn't have got involved in the first place. Need I say more? Well, yes, because for those of you, because for the record and the benefit of those of you present today who are carers who have had a stroke, I have never had to take a pill or a potion as part of my participation in stroke research. So you've got nothing to fear from getting involved. You can choose the studies you want to get involved with anyway. So as far as my continued motivation to keep involved is concerned, and this is where it really resonates with Toby's introduction, I only have to consider some sad truths about stroke, such as, according to the Stroke Association in the UK, 5 in every 100,000 children in the UK have a stroke. That's 1,000 children a year. But who knows about that? How many 7-7s or Hillsboroughs is that? When was the last time you saw a media headline about children having a stroke? Fewer than 1 in a million children have an adverse reaction to immunisation. But when was the last time you saw a media headline about children having a potentially bad reaction to immunisation? Well, I'll tell you, it was on daytime TV. Those of you who are stroke survivors know what daytime TV is like. It was on the 15th of July this year regarding public concerns about UK human papillomavirus immunisation policy. But more poignantly, what's been the consequences of this misplaced media involvement? I was a child growing up in the 1960s when measles was rife and feared by everybody. By the 1980s, we'd beaten measles with cost-effective, relatively risk-free immunisation. But then following a media storm of scaremongering around the safety of the MMR vaccine a few years ago, immunisation rates have plummeted and measles is back with a vengeance, along with its consequences of childhood blindness, encephalitis, and 1 in 5,000 children dying. It makes me really sad to think about that. But what's it got to do with stroke? Well, we really should be doing much, much more to make everybody fully aware of the reality of stroke. Let's start to put risk into a real perspective. Today's part of that process, because we all know that stroke can affect anyone of any age, of any gender, of any ethnicity, at any time. It's not just a condition which affects the frail and elderly. despite my sons constantly reminding me that each year I get a bit older. But even they can't actually say I'm frail. But we all have a part to play to try and improve awareness of the reality of stroke. Let's start with NICE. And as recent figures published in the American Academy of Neurology journal suggest, 1 in 5 strokes in the USA now affects the under 55s. So we've got a lot of work to do in the coming years. It's weird, though incredibly rewarding, how my research activities have now shifted from Birmingham to Kiel and are becoming heavily focused in the Northwest, with Chris Hollands and a team of PhD students in Salford and Fiona Rowe's work in Liverpool, and not forgetting Caroline Watkins' work at UCLan. But I have to confess that I have a very special loyalty reserved for Christine Roth, who's given me the most amazing support and encouragement ever since I joined the West Midlands SRN back in 2009. So gait, rehabilitation, vision in stroke, and optimising patient care. What an interesting and eclectic combination of stroke research specialisms. I love it, because 10 years post-stroke, I'm still improving, physically and cognitively, busting those stroke myths year on year, enabling me to live a rich and rewarding life again. However, I hold all of you responsible for my love of exotic holidays, because I've witnessed so many presentations at conferences over the past 6 years, mainly by Professor Tom Robinson, that have included slides of interesting holiday destinations. So thank you all for inspiring me to visit Sri Lanka, Jamaica, Cuba, Mexico, Costa Rica, and Myanmar, to name but a few since 2012. And here's the evidence, okay, where I've ridden elephants.
You have seen them?
Yeah. No, zip wiring. So elephants swimming with dolphins, stingrays, walking through snake-infested jungles, zip wiring down volcanoes, and eating lots of interesting food. So there's the evidence. This year, in a few weeks' time, I'm going to Uzbekistan and then India in November. Next year, it's going to be Ethiopia, Iceland, and Bhutan, purely to test how my ongoing rehabilitation is going. But when disability as a consequence of stroke remains stubbornly at around 30% of stroke survivors, and I'm ignoring the reductions in physical disability with the more widespread use of thrombolysis, there's still no real evidence that thrombolysis reduces psychological and cognitive disability post-stroke, and over 60% of stroke survivors experience disruption of their visual systems, but it's rarely diagnosed before discharge. We still face lots of challenges to break down the numerous barriers that stand in the way. Sorry, almost finished. You can wake up again soon. So we still face lots and lots of challenges to break down the numerous barriers that stand in the way of public participation. Because at the very least, once you've hooked your trial participants, you've then got to keep them, which is, I think, a fairly straightforward task for inpatients, unless they die. Sorry, it's a bit dark. But for outpatients, it becomes more challenging, because believe it or not, once we've been discharged, we actually have our own lives to lead. Perhaps the real challenge of patient-friendly rehabilitation research in the future is to try and tailor rehabilitation research protocols for direct use in the patient home environment to optimise patient engagement. That's an option that we're trying to work up in Salford with Chris Hollands for the VCT trial. I don't know if we'll achieve it, but at least we're giving it some thought. And I know you're all doing your best to remove these barriers, and I recognise the progress that's been made in increasing patient participation rates since 2005, but barriers, both real and imaginary, remain very, very real for the majority of patients who wish to get more involved. There can be life after stroke, but when you've lost everything, it's incredibly hard to put your life back together unless you're lucky enough to have the right support and encouragement to bolster your own bloody-mindedness. So in conclusion, what have I deduced from my experience of recovery from stroke over the past 10 years, and how does research fit in? Well, firstly, stroke services still need to change, because there's always going to be frail and elderly stroke patients, and more of those patients are surviving as mortality rates change and fall. But at the same time, the numbers of young stroke patients are increasing, and we need more appropriate rehabilitation facilities, because these stroke survivors are going to live for many more years than current patients. So they're going to require a much longer period of active rehabilitation, and that costs money. So we need to find new, smarter, more cost-effective physical and psychological therapies. And in conclusion, my conclusion is rehabilitation research is paramount in driving and delivering this change. Thank you so much for your attention.